If you're over 70 and your doctor is cheering because your blood pressure is exactly 120/80, but you feel like the room is spinning every time you stand up, you aren't getting healthier. You're standing on the edge of a systolic cliff that causes thousands of preventable fractures every single year. What if I told you that for an 80-year-old, a blood pressure of 145 might actually be safer than a blood pressure of 120? Today, we're exposing the perfect number myth and the 3-minute living room test that could save your independence. I want you to meet Evelyn. Evelyn is a 79-year-old retired librarian I saw recently in Savannah, Georgia. She's the kind of person who follows every medical instruction to the letter. For years, her blood pressure hovered around 150, and she felt great. She gardened, she walked her dog, and she never felt a hint of dizziness. But at her last checkup, her doctor decided they needed to be more aggressive. They added a second medication to force her numbers down to that textbook 120/80. By the time she reached my office, her numbers looked perfect on paper, but Evelyn was a shadow of herself. She told me, "Dr. Vance, the world tilts every time I get out of my chair. I'm terrified to walk to my own mailbox." A week later, at 2 a.m., Evelyn got up to use the bathroom. Her blood pressure cratered, she lost her balance, and she hit the floor. That perfect 120/80 led directly to a fractured pelvis and a total loss of her independence for 6 months. I'm Dr. Elias Vance. I've spent the last 25 years specializing in geriatric medicine, specifically focusing on a field we call deprescribing. This isn't about being anti-medicine. It's about right-sizing. It's about recognizing that a body at 80 does not function like a body at 40, and when we try to force a senior's biology to match a younger person's metrics, we often create a medical disaster. In my practice, I see this every day. We've been conditioned to think that lower is always better when it comes to blood pressure. But in the medical world, we use something called the U-shaped survival curve. Imagine a U, so en der there. If your blood pressure is way too high, at the top right of the U, your risk of stroke goes up. That's what we all know. But if you push that pressure too low into the bottom left of that U, your risk of falls, kidney failure, and even heart attack starts to climb again. For my patients over 75, the sweet spot is often much higher than you've been told. Before we go deep into the why, I need to ask you a quick question. Are you currently taking more than one medication to control your blood pressure? Just comment yes or no below. I'm asking because polypharmacy, taking multiple drugs for the same condition, is the leading cause of the systolic cliff I'm about to describe. Seeing your answers helps me understand how many of you are being pushed into these aggressive targets. What happened to Evelyn wasn't an accident. It was a predictable biological failure. You see, as we age, our arteries change. Think of a young person's arteries like a brand new, flexible rubber band. They expand and contract easily to keep blood flow steady. But by the time we hit our 70s and 80s, those rubber bands have become more like rigid PVC pipes. They are stiffer. Because those pipes are stiff, your heart actually needs a little more pressure to push blood all the way up against gravity to reach your brain. When we use heavy medication to artificially drop that pressure to 120, we aren't fixing the pipes, we're just reducing the flow. For someone like Evelyn, that meant every time she stood up, her brain was momentarily starved of oxygenated blood. That's the systolic cliff. One second you're fine, the next, the lights are dimming. This is what many call orthostatic hypotension, and for seniors it is far more dangerous than a slightly elevated blood pressure reading. We are so focused on preventing a stroke 10 years from now that we are causing a hip fracture today. And I want you to understand, for a 120-pound woman in her 80s, a broken hip is often more life-threatening than a blood pressure of 145. So, why does your body stop being able to adjust? Why did Evelyn feel fine at 150, but like she was on a tilt-a-whirl at 120? It comes down to 3 hidden biological changes that happen as we age, things your standard 15-minute doctor's appointment almost never covers. Let's look at those next, because once you understand the sluggish thermostat, you'll see why your medication might be working against your own survival. Inside your neck, right along your carotid arteries, you have tiny pressure sensors called baroreceptors. You can think of them as your body's internal thermostat for blood flow. When you are 25 years old, this thermostat is lightning fast. If you are lying in bed and suddenly jump up to answer the door, gravity instantly pulls your blood down toward your legs. But within a fraction of a second, your healthy baroreceptors detect the drop in pressure, signal your heart to beat slightly faster, and tell your blood vessels to clamp down. The pressure normalizes before you even take your first step. But as we age, this thermostat gets sluggish. By the time we reach our late 70s, those sensors take a few extra seconds to realize you've stood up. The signal to the heart is delayed. The blood vessels respond just a little too slowly. Now, if your resting blood pressure is sitting around 140 or 150, you have a built-in safety buffer. Even if the pressure drops temporarily when you stand, it doesn't drop low enough to starve your brain of oxygen. You stay steady on your feet. But what happens when you are heavily medicated to keep that top number strictly at 120? You lose your entire safety buffer. When that sluggish thermostat fails to adjust quickly, your pressure plummets from 120 down to 90 or even 80. Your brain is briefly deprived of oxygen, the room spins, your knees buckle, and you fall. This is why aggressive medication targets in older adults often cause exactly what we are trying to prevent: catastrophic injury. Which brings us to the second massive misunderstanding in senior blood pressure management: the danger of the diastolic floor. We talk so much about the top number, the systolic, that we completely ignore what happens to the bottom number, the diastolic. Let me tell you about Arthur, an 82-year-old former long-haul trucker from Des Moines, Iowa. Arthur's primary care doctor was very focused on getting his top number down to 120. To do that, they kept increasing his dosage. Eventually, Arthur's top number hit 125. The clinic was thrilled, but Arthur came to me because he felt a heavy, dull ache in his chest every afternoon, and he was too exhausted to play with his grandchildren. When I looked at Arthur's chart, I saw the hidden danger immediately. Yes, his top number was 125, but his bottom number, the diastolic, had been forced down to 54. Here is the biological truth that you must understand. Your heart muscle does not get its own blood supply when it squeezes. It only gets its blood supply when it relaxes. That relaxation phase is your diastolic pressure. If you push that bottom number too low, usually below 60 or 65, your coronary arteries simply do not have enough pressure to feed oxygen to your own heart muscle. Arthur's heart was literally starving for oxygen because he was over-medicated. We didn't add a heart pill. We safely and gradually tapered his blood pressure medication. His bottom number came back up to 70, his chest pain vanished, and his energy returned. This leads to the third hidden change, and it is the one that terrifies my older patients more than anything else: the medication fog. Meet Miriam, a 74-year-old quilter from Bend, Oregon. Her daughter brought her into my clinic in tears, convinced that Miriam was developing early-onset dementia. Miriam was losing her train of thought mid-sentence, forgetting the patterns she had quilted for decades, and spending most of her afternoons staring blankly at the television. She had recently been put on a heavy dose of beta blockers and diuretics to aggressively treat her hypertension. I want to pause right here and ask you, which of these scenarios sounds most like you or someone you love? Have you ever had these moments of sudden fatigue, dizziness, or brain fog and just brushed it off as getting old? What was happening to Miriam was not dementia. It was chronic, low-level hypoperfusion. Her brain was not getting enough blood flow to maintain sharp cognitive function. Her kidneys and liver, which slow down as we age, were metabolizing her medications much slower than a younger person would. The drugs were building up in her system, artificially suppressing her blood pressure to the point where her brain was essentially operating on low battery mode all day long. Through a careful deprescribing protocol, we peeled back the layers of medication. We allowed her pressure to safely drift up to a geriatric target of 140/75. Within a month, the dementia lifted. Miriam got her mind back. This is the reality of the medical lag I mentioned earlier. Universal guidelines are slowly catching up, but many busy clinics still apply a one-size-fits-all approach. They treat a frail 80-year-old exactly the same as a robust 50-year-old. But you have the power to change this dynamic in your very next appointment. I want you to write this down. The next time you sit in your doctor's office or speak with your pharmacist, do not just accept a nod of approval when your numbers are low. Ask them this exact question: "Doctor, given my age and my risk of falling, should we be looking at a personalized geriatric blood pressure target instead of a standard adult target? And are we making sure my diastolic number isn't dropping below 65? That single question completely changes the conversation. It signals to your doctor that you understand the difference between aggressive treatment and right-sized care. But before you have that conversation, you need data. You need to know exactly what your blood pressure is doing in the dangerous moments when you transition from resting to moving. Next, I am going to walk you step by step through the exact 3-minute living room test you can perform tonight to see if you are standing on the edge of the systolic cliff. To do this test, you don't need a medical degree and you don't need to wait for your next clinic visit. You just need a standard automatic home blood pressure cuff, a piece of paper, and 3 minutes of your time. This is called the Orthostatic Vitals Check, and it is the absolute best way to see if your medication dosage is out of alignment with your aging biology. Here is exactly how you do it. Step 1. Take your blood pressure cuff and lie completely flat on your back on your bed. Close your eyes, breathe normally, and rest there for exactly 5 full minutes. Do not talk. Do not watch television, just let your cardiovascular system completely relax into a resting state. After 5 minutes, while still lying flat, push the button on your cuff. Write down the top number and the bottom number. Step 2, take the cuff off or leave it loosely attached if it's comfortable and carefully stand up. I want you to stand right next to the bed so that if you feel unsteady, you have a safe place to sit immediately. Stand perfectly still for exactly 1 minute. Don't walk around the room. After that 1 minute of standing, take your blood pressure again. Write down those 2 numbers. Step 3, remain standing for 2 more minutes. That makes a total of 3 minutes since you got out of bed. Press the button and take one final reading. Write those numbers down. Now, look at your paper. We are looking for the gap. So if your top number, your systolic pressure, dropped by 20 points or more when you stood up, or if your bottom number dropped by 10 points or more, your body is failing to compensate for gravity. For example, if you were 135 lying down and you dropped to 110 after standing for 3 minutes, you have hit the systolic cliff. This right here is the hidden culprit behind so many unexplained falls. When you take this piece of paper to your doctor, you completely change the dynamic of your appointment. You are no longer a patient vaguely complaining about feeling dizzy. You are an empowered adult providing concrete, clinical evidence of orthostatic hypotension. When you slide that piece of paper across the desk, you say, "Doctor, my systolic pressure is dropping 25 points when I stand up. I am concerned that my current medication target is too aggressive for my age, and I'd like to discuss a safe tapering plan to find a geriatric target." Notice that I used the word tapering. I have to be incredibly clear about this, and please listen to me carefully. You must never, under any circumstances, stop taking your blood pressure medication on your own, and you should never cut your pills in half without your doctor's direct supervision. Blood pressure medications change the way your kidneys process sodium and the way your blood vessels constrict. If you stop them cold turkey, your body can experience what we call rebound hypertension, where your pressure violently spikes to dangerous levels, severely increasing your risk of an immediate stroke. Right-sizing your medication is a process of gently peeling back the layers over weeks or months, and it requires a medical partner. When you find a doctor willing to be that partner, the results are life-changing. Let's go back to Evelyn, the 79-year-old retired librarian in Savannah who fractured her pelvis because her clinic pushed her down to that textbook 120/80. After her fracture healed, she came to my clinic terrified that she would fall again. She was considering moving into an assisted living facility because she simply couldn't trust her own legs. We didn't prescribe her a walker, and we certainly didn't prescribe her more pills. We looked at her orthostatic vitals, and we slowly, safely deprescribed one of her intensive medications. We allowed her resting blood pressure to naturally elevate to about 145/75. To a doctor treating a 40-year-old, 145 looks like a failure. But for Evelyn, 145 was exactly the pressure her aging, stiffened arteries needed to push oxygenated blood up to her brain. The dizzy spells completely vanished. The brain fog lifted. Today, Evelyn is back in her own home, walking her dog every single morning, and she hasn't had a single fall in over 2 years. She didn't need to be fixed. Her medical targets just needed to respect her biological age. We have to stop treating aging like a disease that needs to be medicated down to 0. Your body is incredibly intelligent. Sometimes, a slightly higher number isn't a sign that your body is failing. It's a sign that your body is adapting to keep you safe. Now, I want to hear from you. This channel is a community, and your actions matter. I want you to choose one of these 3 options and leave it in the comments below. Comment the word base data. If you are going to perform the 3-minute home postural test tonight to see where you stand, comment the word or key sensor talking. if you are going to take this exact information to your doctor or pharmacist this week. Or comment the word "crane" saved if this video finally explained a dizzy spell or a moment of brain fog that you've been quietly worried about. A single preventable fall can change an older adult's life forever, stealing their independence in the blink of an eye. You have the power to stop that from happening. Send this video to anyone you know over the age of 75 who takes daily medications. Share it with a caregiver, a spouse, or a friend. It might just save their hip or their life. If you want to keep learning how to protect your health and your independence as you age, hit the save button on this video so you can easily find the test instructions later, and make sure you subscribe to the channel. I'm Dr. Elias Vance, and co-secundar Sir Diasis, and I'll see you in the next video.